Archimedes, which is the Archimedes effect. When you have this roller that rolls, you can move water around, and that's sort of one of the starting points for some of the mechanical support. So today we're going to be talking about durable MCS. We're going to do a quick overlook of what it is, how they work, what are the indications and contraindications, and any pre-op workup that needs to be done, as well as the implantation technique, some of the common complications and issues to be looking for after the operation, and what are the trials and outcomes, especially the current ones. So LVADs are mechanical devices that are designed to partially or completely take over pumping function of the left or right ventricle. There's many differences, and depends on how you look at them, different types. So if you're looking at duration, there's short-term, long-term VADs. There's paracorporeal or intracorporeal. That's going to be involved in regarding where the pump is. If the patient's blood is being brought out of the patient to be pumped back into the patient, then it's going to be a paracorporeal device. The current LVADs that we use and that you guys all know, like the HeartMate 3, is intracorporeal. And then there's going to be pulsatile versus continuous flow. And right now, most of them are continuous flow, the ones we commonly use. And then the other definition that's important is to think if they're going to be assist devices or replacement devices. So assist device, it's all in the name. They're going to be there to help the heart do its function. And replacement devices, they're going to take over completely the function of the heart. And there's different indications. Some are used in cardiogenic shock, some as a bridge to a transplant, some as a bridge to therapy, some as destination therapy, and some as a bridge to decision. So it all started in 1967 with Dr. Debicki, who did the first implant. And it's sort of a conflicted or controversial story that the device was designed by Dr. Cooley in his lab, and Debicki did the first implant, even though he wasn't supposed to. So that created some contention between the two. And then Dr. Cooley did the first one that was used as a bridge to a transplant, which if you see, it's already a bit more than 10 years after the first implant. The first FDA approval of an LVAD was even, further than that in 1994, which when it was approved, the HeartMate for a bridge to transplant therapy. 2001, we did the rematch trial, which was a trial comparing LVADs to medical therapy only. And it showed an advantage for the LVADs in patients that were not candidates for transplant. And since then, there's been continuous improvement. And we arrive at what we use today, which is continuous flow pumps. And in 2006, the INTERMAX database was created to study the use of these devices and see how to optimize it and make it better. So the most common one, and the one you'll most likely see, it's going to be a HeartMate device. We'll talk about what's available nowadays, but it's evolved quite a bit. It started with the XVE LVAD, which is the one we see Dr. Cooley holding, or at least the precursor of that. Sorry, Dr. Debicki. And as you see, these devices were huge, quite bulky, and they needed to be implanted in the peritoneum, in the abdomen, or some peritoneal pocket or fat, to be able to house this whole device. We don't see this anymore. And then a graft was sewn to the apex of the LV, from where the blood was being passing through that graft into the pump itself, and then back into the ascending aorta through an outflow graft. The device was super bulky, uncomfortable, and it's been evolving. I don't know if you guys can see my cursor or not, my pointer.
Yes, we can see it.
Yeah, okay. So it's been evolving to the HeartMate 2, which we see here, which is much smaller, but still required extra pericardial pocket for it to be placed. And you can see an X-ray there on the right side. And to what we use now, which is the HeartMate 3, which is much smaller device, completely intrapericardial. And we'll go through the components of the device in a second. And what makes it work is the technology that they patented called the maglev flow technology, which is the way that the rotating part of the device is held, being levitated magnetically inside the housing, and then being rotated through electric currents. So it's fully levitated and self-centering, so it doesn't move to the sides. It always stays centered in this space. And there's no need for any bearings or anything to hold it, which is one of the things that breaks. So avoiding using that makes it more durable. The other thing is the blood flow pathways are larger and consistent. So meaning that the blood is always going to go the same way, and there's less turbulence and ebbs and webs that can cause shear stress and can cause thrombosis of the mechanism. And it's going to have some pulsatility, which we're going to look at. So that's a little bit on the maglev technology. So it's just magnetic pieces that are electromagnets. So with electricity, you make this rotate, and it's completely centered in the right spot. So this is the pulsatility. And I don't think it's them that came up with it. It was the HVAT that had the Lodewyks cycle, which is shown in red. And what it means is that the RPM and the way the pump is rotating is going to change. And this changes in velocity or rotation help prevent blood from stagnating and create a little bit of a washout of the pump and all the parts. So the Lodewyks cycle was at once every 1 minute, and it would cause a change there that we see in red. The one that the HeartMate 3 uses is much more frequent and much more higher in amplitude. So you see it goes to very high RPM to very low RPM, and it keeps oscillating like that. And they found that that keeps the device cleaner from any clot and stuff like that. A little bit on the size comparisons of all the VADs that can be used, and this one doesn't have the HeartMate 3, and it does have the HVAD. So the HVAD is very small. It was great in terms of size, but as we'll see, the results are not as good as the HeartMate 3. So HeartMate 3 is a little bit bigger. So then we start asking questions regarding, how do we select who we're going to put an LVAD in? So one question is why use an LVAD? Who are we going to VAD, and when are we going to VAD them? So this is just a small case to talk about this. And the first case is a 58-year-old male. He has past medical history of hypertension, comes to the ER for shortness of breath and leg swelling. He's an active smoker, smokes 1 pack a day, drinks 6 to 7 beers per weekend, and he works as a cook at a restaurant. So we see his vitals there. Everything looks pretty good. His blood pressure is a bit on the lower end, but his saturation is also on the lower end on room air. He has pulmonary edema. He has sinus tachycardia. His creatinine is a little bit high, and he gets diuresed in the ER with good response, but he's admitted to cardiology for a workup. Echo found an EF of 20%, moderate MR. His LV is quite big, 7 centimeters in diameter, and then diastole, moderate TR, no AS, no AI. So then the question comes, is this a good candidate for an LVAD? So he gets medical treated. 1 week later, he's well diuresed, feels better. He's still a little bit short of breath with minimal ambulation. It's been going on for months. Should we take this patient for an LVAD? So no, optimal medical management hasn't been tried. So that's what this patient got, and it's usually a combination of beta blockers, diuretics, and Entresto. And then the patient also needs to be worked up to figure out why he's heart failure. So a cath and a possible biopsy. So there's minimal atherosclerosis. He's pretty free of coronary artery disease. Has no significant coronary artery disease. And then on his right heart cath, we can see that he has a PAPI, which is a right-sided work index, really. That's telling us how the RV is working. It's telling us that it's pretty good. Anything under 1 is pretty bad. Over 1.5 is pretty good. In between both is borderline. So in his case, he has an RV that's working well. Well, if I have time to make this just to show you something, one of the things we tend to simplify in our minds regarding PA pressure and RV failure is whenever we see a patient with high PA pressures, we think RV failure. But if you stop and think about it, elevated PA pressure does not mean right hearted failure. In reality, it should sort of mean the opposite. And the way our brain works is because we associate both conditions at the same time, which is pulmonary hypertension, which does cause RV failure. We think that if they have elevated PA pressures, they have RV failure. But it's the opposite case. That's the afterload, and that's what the RV is fighting against. So if it goes up and they have pulmonary hypertension, it will develop RV failure, but not necessarily. So this patient is able to pump against that pressure, and only with that right atrial pressure of 17, which is high, but it's not as high. And that's where the PAPI comes into. And what it does You subtract the difference between your systolic and diastolic pressure in your pulmonary artery and divide it by your right atrial pressure. And it's a very good indicator of how well your right side is working. So the patient gets discharged. 3 months later, he's doing great. His shortness of breath has greatly decreased. His euvolemic and his EF is 35%. So the drugs are working. We're pretty happy with that. So heart failure has 4 stages. It also can be analyzed from a preserved versus decreased ejection fraction. There's a lot of people with preserved DF that do have heart failure. And another useful way of classifying it is the NYHA classification. There are many causes of heart failure. I'm sure you all know them well, but probably anything can cause it. And this is a little bit of the staging, how we divide the stages. C and B are really patients who are in heart failure. A and B are more at risk of it. And it's a gradient. And most of the patients we're seeing are going to be stage D. Patients who are established heart failure, they're symptomatic, and they keep coming back to the hospital for it. And this is another classification that's going to be important for you guys to keep in mind, which is the Intermax classification. And this helps us sort of see how acutely ill are these patients. It's not a chronic marker, although it does give us an indicator of how they're going to do over time. But it's fairly easy to memorize, and they ask for it frequently on exams. So it's good to learn it. And in the end, it's going to be level 1 are patients that are on ECMO, not doing great at all and about to die. And patients who are 7 are patients who are at home and doing great. And everything in between is what we're going to see. Most patients that we intervene in as a heart failure team are going to be, or as a heart failure surgical team, are going to be between 1 and 3. We do see some 4s sometimes. And this is another mnemotechnic for people to know when to call heart failure, which is called I need help. And it's going to be a lot of indicators that are probably very obvious that are patients who probably would benefit from a consult to heart failure. So that's that. So we go back to her case, and we saw that he was very low intermax level, and he was probably a stage BC at that time. And he probably turned into a stage B with that medical management. But now he comes back a year later with 2 readmissions for fluid overload. So he's starting to go towards a C, maybe D, subjective decrease in quality of life, not able to take care of himself. EF now went back down to 20%, and he's admitted for IV diuresis. So if we look at Intermax, he's admitted for IV diuresis. He's probably going to be between a 4 and a 5. And starting to get towards a 2, sorry, a 3 and a 4, starting to get towards a 2 if he ends up on inotropes. So he had another right heart cath, and we see the PAPI 45 minus 15 is going to be 30 divided by 1.5 is going to be 2. So that gives us that he does have a good RV, but he's hypotensive in the hospital, started on IV milrinone, so he makes it to a 2. What are his options? So things to look into are going to be the social support for this patient. It's not mandatory that the patient has family that lives with him, but it's good that they have help and people that can help them. Mental capacity for sure. It's not easy to take care of the pump, and they're going to need help making sure that they're good at that. So usually you could do a good assessment to see if they're going to be able to use it. And then commitment. These patients their mortality without intervention, we're talking about 50, 60% at a year or 2. So it's a pretty end stage disease. So it's easy to tell them you don't have a choice. This is the only thing that's going to save your life. But it's always good to take 5-10 minutes or even more to sit down and explain really how their life is going to change. And their life is going to change a lot if you put an LVAD in. So it's always good to discuss with them. Sometimes what we do, we bring patients who have an LVAD and have them meet and talk about things, and then see if the patient really, that's what they want. And there's a lot of other variables that can be involved. They don't want to disappoint their family by giving up. They don't want to, they're afraid of dying. But once you present things very directly, sometimes they choose not to proceed with an LVAD. And it's important to do that. We do want to help as many patients as we want, but the last thing we want to see is that we put an LVAD on someone and 2 or 3 months later, they say they don't like it and they stop it and die. So it's better to have patients who are very committed to this operation. So what are the contraindications? As we said, the RV dysfunction is a significant one. On patients that we know that the RV is not going to tolerate, usually at the time of the operation, we put the LVAD, and then they end up in profound RV failure. We'll talk a little bit later of what we can do for that, but once a situation arrives, it's usually temporary mechanical support that gets them through that hump, but even then, sometimes it never recovers. And then we're considering using another HeartMate 3 to do right ventricular support, which is not ideal, doesn't work as well. End organ failure as a relative contraindication, renal and hepatic, especially renal in the relative terms, and hepatic is more of a real contraindication. If they have some kidney failure and we think it's caused by cardiogenic causes, then usually putting the LVAD will improve. But patients who are already dialysis and not having severe end-stage renal disease, they're usually not good for LVAD, and their outcomes we know they're worse. But sometimes it's the only tool we have. Severe neurologic injury is pretty obvious. Sepsis, we're going to be implanting a machine that's going to be in contact with the patient's blood all the time. So if they're already infected and sick, they're usually not going to tolerate or survive the procedure. Respiratory failure is also critical. If the patients are already on respiratory failure, they usually don't recover that and will lead to prolonged ICU stay and usually failure of the operation. Liver dysfunction, it's going to be predictive of adverse outcomes. Renal dysfunction, if it's caused by low cardiac output, can improve with LVAD, but otherwise it could be a real issue. So right now we only have one real available option, which is the HeartMate 3. We used to have the hardware, but it got pulled off the market, and we'll see why later. Usual pre-cardiac surgery precautions are needed at the time of implant. And the RV failure risk has to be assessed and considered. If it's high risk, then you have to be prepared for an RVAD, and we'll talk about that later. All lines have to be removed, and new lines should be inserted on the day of surgery, so we prevent infection of anything that's already colonized. And then the approach needs to be determined. The most standard approach is a sternotomy, although there are other approaches like hemisternotomy and thoracotomy or bilateral thoracotomy. And then the last question on those terms are if the procedure is going to be with a beating heart on pump, which is the most common way to do it, or off pump, or sometimes even with arrested heart if there's other things going on. So what are the steps? We start with the midline sternotomy. We usually spare the inferior pericardium. I use that to cover the drive line and the outflow graft so that there's a barrier at the time of reentry for transplant. I spare the thymus. You try to keep as much of that fat and thymus possible and put it between the sternum and the device. Avoid pledgets. Usually heart failure surgeons tend to avoid pledgets, but they're not a major issue if they're there. Avoid opening the pleura. So the least invasive or the less stuff that can get stuck to your device, the better. And if there's a tricuspid repair to do, I usually start with that repair. So for cannulation, it's central. So I put the aortic cannula not too high. There's no need to go in the arch or higher up. So usually what I do, I don't clear the pericardial reflection up here, and I just cannulate right under that reflection. For venous drainage, usually it's a single unless there's a reason not to. And in those cases, it's bicaval, for instance, if you're intervening on the tricuspid valve. Sometimes we do peripheral cannulation. Patients who are on ECMO at the time of implant, we usually use those cannulas for the cardiopulmonary bypass. Avoid, and I said, avoid platelets or other foreign material, but sometimes that's not possible. After going on pump, we want to lift the apex. So we use lots of sponges to bring that apex into full view. And then we have to identify it. Once you learn to identify it, it becomes fairly easy. There's anatomical landmarks that you're going to see. Main thing is going to be to identify the LAD, and you're about 2 fingers lateral to that. The other thing is going to be once you look at the muscle and the way it's contracting, usually you can see like the vortex point, which if you've seen the heart beat in this way, you know that the heart doesn't beat like a sack. It beats more like a spire, and it all ends up in one point, and that's the dimple. And you can feel it with your finger, or you can see it sometimes. And that's usually the spot you want to do. And then the other thing we do is the finger test, where we push where we think it's going to be. And we look at the transesophageal echo and see if that our finger point or our finger where it's pushing, is it actually aiming directly to the mitral valve, which is what we want. And that's how we identify it. Many times we mark it, and then comes the coring. So the objective here is to attach the apical sewing ring to the muscle. Has to be firm attachment, no tearing, no bleeding. There's many ways to do this. You're going to encounter mostly two. One is going to be you identify the apex and then you core and excise that part of the muscle and be able to look into the LV, clear it of any clots or anything like that. That's one way. The other way is to sew in the ring first. So you still have the muscle intact. You identify where it's going to go. So you sew your ring in place and then you core, which is what's been shown in this picture. And this one, what it does, it sort of accelerates things a little bit. I think it's a little bit faster. I prefer the other way. I usually core first. I think it's more hemostatic because you're sure all your bites go through and through the myocardium. I actually do that twice. So go from the outside of the epicardium in, the pledget stays on the outside there, and then I make sure that that needle comes out through the endocardium, and then I go back out through the endocardium into the muscle and come out through the epicardium, and that needle then goes through the ring. So you would see what the pledgets would be here. Those stitches will be going into the myocardium and then coming out and being those stitches you see here through the sewing ring. But either way, it's fine. It works well. It's whatever each surgeon is comfortable with. The other advantage of coring first is that the muscle is more pliable. So if you need to repair that mitral valve, which we usually put an Alfieri stitch looking down that barrel hole into the mitral valve, is fairly easy. If you have the ring in place, it's really difficult. So that's another advantage of doing it that way. Once everything is set and you're happy with your ring, it's into place. I just got a notification that my connection is not stable. Everything's okay for you guys?
Yep, we can still hear you great.
Okay, perfect. Do you want me to answer questions now or later? Because I have a question for Ali. Should I answer everything at the end, or you guys prefer I
I
go
think
one
we'll
by
save
one?
it for the end. I can read them out to you after.
Perfect. So we'll keep going then. So after the ring is well attached, you connect the pump to the ring and close the connection. The important thing here is to, if there's any clot, take it out and make sure that the path is clear so that the pump, the inflow cannula, is looking directly at the mitral valve and there's nothing on the way. We'll go into a second about the attachment here. So we'll talk about the driveline after, but the way you attach it with the HeartMate 3 is very easy. You can see this is the inflow cannula, so that goes straight into the hole, and then this mechanism here will attach with the sewing ring. There's nothing to turn or twist or anything like that. It goes straight on it, and then this is the locking mechanism, and you push it in. It has to be completely in. This is telling you if it's not completely in, it's not secure, and you only see the little rim there. You can't really open it with your hand. They have a special tool that makes it fairly easy to open if you need to unlock it again. But the idea is that it's not easy to unlock or remove or pull on. And it cannot lock unless the pump is well positioned against the sewing ring. So that prevents that you would partially connect it and then have severe leak around it. I did have that in one patient where I connected the pump and everything was good, and there was this weird bleeding in between. And all I did was pull back a bit on it and then push it back in, and it completely stopped. And that's a thing that does happen. It's very rare, but usually the reps and everybody there know about it, and they'll help you figure that out if it does happen, but it's rare. The tunneling, so the driveline is what gives power and controls it, changes any settings on the pump. The pump itself has a computer in it, so it can do some things autonomously, but it has no battery. So even if it loses power, it's going to shut down. But if it loses part of the components that control it, it can still keep running at the settings that were preset. So that's what those wires are in there for. There's a lot of redundancy, so there's not just one wire. There's many inside that do the same job. So if one breaks or something like that, it still keeps going. but it will know and it will tell you if some wires start breaking. The idea of tunneling it, you want this dry line not to go directly from the pump to the outside. You want to keep some distance, so it should go inside the muscle or under the muscle, in between the rectus muscle and the peritoneum for a little bit, and then cross the muscle and come out to the skin. We'll talk a little bit more about tunneling later, but usually you want to leave all the velour inside the patient. So the drive line has different consistencies, and they have an area that's velour that gets stuck to the tissues and sort of works as a barrier. This is going to be a tube that's going to connect it from the heart to the outside. So it's always going to get colonized from the outside. And if you can imagine it, the bacteria are going to be trying to push in, and this velour is going to act like a barrier for it to get deeper. Because what you want is for that colonization that's unavoidable not to get to the pump itself or the mediastinum, really. Once all of that is in, you drop the heart, so all the sponges are removed, as you see here. And what ends up being left is going to be your outflow graft. The outflow graft has two components, really. One is the outflow graft itself, that's similar to any tube that we use for aortic surgery, for instance, or vascular surgery. And the bend release, which the bend release is going to be, I don't know if we have another, it's here. It doesn't come attached, so it's loose. Once you sit the pump in the right place, you bring the bend release and lock it there. And what it does, it prevents kinking of this line. So it's a little bit more rigid, so that this thing, the outflow graft doesn't really kink. The downside with this is that creates a little space between the outflow graft and the bend release that can get filled up with fibrin and cause some of the issues that we see after. Here we go. Sorry, there's a code blue they're announcing here. So outflow graft to the ascending aorta. Usually we try to keep it as low and lateral as possible. So what I want, if you're imagining this, you're seeing it from the head of the patient. I want the outflow graft, which is coming from the apex, which is on the left side of the patient there, to go along that acute margin of the right ventricle, go along that area, and then come through the side, and then attach here to the ascending aorta. And usually I want it as low as possible, right above that right atrial appendage. And the reason I want it as low as possible, I want that part of the aorta to fly out with the transplant if it needs to. I don't want it to be above it so that it needs to stay or be repaired. There's a couple ways to sew this. I usually just run it with a 4-0 or a 5-0 on the ascending aorta, and that's it. For that, we're not cross-clamped, right? So we use a side-biting clamp, as is shown here in the ascending aorta. Once it's sutured in with de-air, all of that, some people de-air through the outflow graft itself with needles. Sometimes other people put a regular vent on the ascending aorta. I tend to do that if I have room and it's easy, and de-air like a normal case. These are just, well, I don't know, I think I have a slide on transition to pump. It's one of the last things you get to do as an operator. I think most of the LVADs I did during fellowship, I did skin to skin, but my staff was sitting in a chair, and whenever it was time to transition, he would do it. But it's not complicated. I think they just like doing that. And the transition itself, what you do is you start weaning your pump, and you start start weaning your cardiopulmonary bypass as you start your LVAD. And usually you start with low RPMs where you're de-airing the system. Once the system is de-aired and you're pretty happy, you start increasing your RPMs and start coming down on your pump flow. That's going to start filling up the heart, and you're looking at the echo, you're looking at the vitals, and you're looking at your flow and your pump, and you transition like that, going up on the RPMs and coming down on your cardiopulmonary bypass. And then the last step in the OR is going to be to optimize the RPMs. Once you're completely off, protamine is given, you're going to be looking at that echo. And what you want to do is have the cannula pointing directly at the mitral valve and the septum to be straight. If your RPMs on the LVAD are too high, you're going to start sucking down on the septum that's going to start moving towards or bowing towards the LV. That's not what you want. So then you just come down on your RPMs. It's not simple, but once you get used to it, it becomes very routine. There are other ways, as I said, to do this operation. One way is here it's a upper mini sternotomy and a left thoracotomy. We do The other way of doing that is with a bilateral thoracotomy, which is my preferred way. So you do a small thoracotomy on the right side, like you would do for an AVR, right through the second or third space. And it's very easy. It's not complicated. And it gives you the advantage that you completely spare the sternum. And the advantage of sparing the sternum, there's 2 or 3 advantages. For the redo, it's not really that much better. You do get to do the sternotomy fairly quick, but then everything under the sternotomy is going to be stuck. So under the sternotomy, it's like a typical redo. The disadvantage is sometimes this apex is stuck to the lung, so we try to cover it and avoid that and close that pericardium. But the other advantage is most of the pericardium is intact. That helps you prevent RV failure. The last advantage is that they do have less bleeding. And the reason I think is because you're able to look directly at the pump. When you do it through a sternotomy, once you're done putting the pump in, you drop the heart. So this apex is completely gone. So you can't really see. All you'll see is blood coming here from the sides, and you don't really want to be lifting up this heart all the time. So it's going to be complicated. Here, you see it directly. You have direct view into that apex of the heart. So if it's bleeding, you can see it. And sometimes you can even fix it with an easy stitch there. That's it. So how do we take care of these patients after? So these patients are half human, half machine. So it's sometimes it's a bit different than the usual patient care. So some complications that we'll see is right heart failure. It's the one that sort of we talk about and discuss the most. Anticoagulation and bleeding, hemolysis, some organ system failures and infection. We're going to manage their hemodynamics. We're going to talk a little bit about pump settings and system operation, and then prepare for discharge and HeartMate 3 troubleshooting. So right heart failure. So we know how the LV and the RV are so interconnected. And these are the things that are going to be affecting our right heart: afterload, contractility, and preload. Afterload, we're talking about the things that are going to affect our pulmonary pressure. So our ventilation, acid-base status, the PVR that we know that the patient might have already issues with that, and the LA pressure. So if we're not unloading the heart well with our LVAD, for instance, we might have LA hypertension that causes pulmonary hypertension that causes right heart failure. Contractility, we're going to have the native contractility of the heart. That's sort of the baseline of what we have. We might have issues with coronary perfusion that are going to be affecting contractility. The inotrope support, arrhythmias, the patient's on VTAC, the RV is not going to work well, and cardiac dilatation. So if the LV is huge, it might affect how the RV is working, for instance. Or if the RV gets dilated, it also will work worse. And the preload, so volume status, renal function, diuretic response, tamponade, and insufficiency of the tricuspid valve. So how are we going to assess it pre-op? So a patient that is already on significant right heart failure might be a contraindication for the patient getting a HeartMate 3 or other LVAD. And we'll assess this patient as well for right heart failure. So it's going to be preoperative echo. We're going to look at contractility, dilatation of the heart, the valves, and if there's any PFO. I forgot to mention, if there's any PFO, it has to be closed at the time of implantation. If not, the way the pump works, it might create significant shunting. The other thing is, I don't think I discussed with the valves. So any issue with the aortic valve has to be addressed. Any aortic insufficiency gets worse with the LVAD. So if you have mild or even, so if you have moderate or even mild AI, you might want to replace that valve to start with, just to avoid problems down the line. The mitral valve, usually I repair it through the LV itself if it's severe. And the tricuspid valve, usually also if it's severe, I'm going to repair it. The tricuspid valve is more dynamic, so it's not as clear cut as with the mitral valve, and for me. But the tricuspid annulus does dictate a lot in my practice what I do with it. If the annulus is severely dilated, I'm usually going to put a ring there. So if the patients, we have a suspicion or we're preparing the patient for an LVAD, I always get a right heart cath. That's going to tell us really how the RV is working. So for me, echoes are great, but for the RV, they're not ideal. I prefer a right heart cath really to tell me what the RV is doing. And there's a lot of things we can do to prevent the RV failure. If we're treating the afterload, nitric oxide or Flolan are going to be the mainstay of our treatment. Device setting, of course, is going to help decrease the afterload, as I said, through the left atrium, pulmonary arteries, and then right ventricle. The ventilator has to be optimized because the patient has to have a normal pH. The pH is going to be, it's going to affect quite a bit our pulmonary resistance. Patient has to be warm, temperature is going to affect as well, and minimize transfusions. Contractility, the inotropes are going to help. Weaning from cardiopulmonary bypass slowly and well is going to also help protect the RV and avoid air entrainment. So any bubbles could cause that go into the right coronary can affect the RV. We'll keep an eye on that septum to make sure we don't overdrive the LVAD, causing the septum to shift, treat any arrhythmias, and if needed, pace the RV. And then for the preload, for sure, optimize these patients before surgery. It's not a good idea to take a patient to the ER if they're in anasarca. Sometimes you have to. Address the tricuspid valve insufficiency if needed. Avoid bleeding, which is obvious, and control preload, avoiding high CVPs. So if the CVP is elevated and the LVAD is having low flows, we usually get an echo, and it will help us assess the volume status and contractility. So if you think about it here, every time your CVP suddenly shoots up and your LVAD flow starts coming down, it's usually an indirect indicator that you have some RV failure because you're not able to push blood forward, yet your CVP keeps going up. So you want to evaluate the size and contribution of the right side, assess the tricuspid valve and PFOs, etc. And then if everything looks like it's RV failure, you want to be very aggressive and intervene early. The longer you wait on the RV, the longer you are on high inotropes just to try to support it, the more issues you'll have down the line. So echo can be important in giving us this assessment intra, post, or pre-op, intra-op, and post-op, and will give us an information about how the LVAD is working, how are the valves, pump speed, septal shift, and all these things. So it's at the beginning, the first few hours after the implant can be very complex, and as time goes by, it becomes much simpler. When to extubate the patient, so it's really going to depend for me if the patient is on nitric oxide or not, and if their ventilation is normal. If they're ventilating normally and not on nitric oxide, usually we need to extubate. If they're having issues ventilating, we'll postpone it. If you do a borderline extubation where you're not sure, you can get into serious trouble with the RV. So it's better to hold off a little bit. In terms of bleeding and anticoagulation, you're in between a rock and a hard place in this patient. It's you need to anticoagulate them, but they are also more prone to bleed. So it's complicated sometimes. So you can have bleeding anytime and for multiple reasons. Sometimes people place the HeartMate 3 off bypass to give them a little bit of the less time you spend on heparin, the better. So some people tunnel, prepare the outflow graft and do these things before giving heparin. And I'm not sure how much that's really going to help. And then after the surgery is done, we completely reverse anticoagulation, give protamine like normal, and leave the OR with the patient completely non-anticoagulated. And then a few hours later, if there's no bleeding, everything looks good, you can start anticoagulation slowly. Usually, if you have the pump working well and at the beginning at high RPMs, you shouldn't have any issues. Yeah, so once the chest tube drainage has decreased, we start anticoagulation. I usually go slow, but by 48 hours, usually I want to be fully anticoagulated. So this is a little bit about the management of anticoagulation. So in the OR, you completely reverse 12 to 24 hours. You start IV heparin, depending on the chest tube drainage. Usually start low, and then 24 to 48 hours go all the way. And then, after 48 hours, you should be completely anticoagulated with heparin. And then comes the question of starting aspirin. There's new evidence showing that probably not needed, but it's not strong enough for us, at least as a center, to stop giving aspirin. So we're still giving aspirin to our LVADs. If they have any significant bleed post-op, then we stop it. That's about it. Coumadin is started after, once we're happy that the patient is not sick in the ICU, that the heparin might need to be stopped abruptly. And then the target initially is going to be 2 to 3. So there's many types of bleeding that can happen. GI bleeding used to be very common in the HeartMate 2, and one of the major problems. And the one of the things that has been thought to be an issue is the reduced pulsatility. The HeartMate 3 LVAD has less issues, and it's been trying to investigate why. But that's being worked out. What else? So the other issue is going to be on the other side with thromboembolic events, ischemic and hemorrhagic issues. So we don't want low flows on the pump. So 3 liters per minute is usually ideal. Anything below that, you start having higher risk of having clots forming. And you don't want to over-anticoagulate these patients either, because they can have hemorrhagic strokes. And infection has a potential to increase the risk of stroke and bleeding as well. So another issue that you want to be monitoring this patient is hemolysis. It does happen, and the reason why is the blood is being circulated through the pump, sometimes in a quite aggressive way. And you want to control then the plasma-free hemoglobin or the LDH. LDH is usually going to be your first indicator that something's up, and then you work it up. Sometimes when patients come from home with hemolysis, it's fairly easy to figure it out. They're anemic, and they're going to have this hemoglobinuria. And this can happen at any time. Usually in patients that everything is good and they have no hemolysis, and then come in a few months later with hemolysis, you know that something might be wrong with the pump. So you have to work it up to find if there's any outflow graft extrinsic compression or any thrombus in your mechanism that's causing this hemolysis. So you want to do an echo, look at the RPM, maybe it's too high, see if there's any inflow or outflow occlusion. You want to see that the pump position is okay. Sometimes with the chest anatomy, the ribs or something are pushing on the pump and kinking it, and that could be an issue. Liver dysfunction could be a problem as well. If there were blood products recently used that could cause hemolysis, infection, and try to correct the sources. Sometimes you can reduce the pump speed if the patient is able to tolerate that to decrease hemolysis. So pump thrombus, how you want to decrease the risk of that? You want to avoid the low flows. So as I said before, create unobstructed blood flow path for the inflow cannula, prevent migration, make sure it's sitting on the good position, and avoid low speeds. You also want to avoid high blood pressure. The higher your blood pressure, the less flow is going to be through the pump. And it just makes sense. It's because it's a centrifugal pump, so it's not responsive to afterload. So if your afterload increases, the only thing that happens is the flow decreases. You want to heparin bridge when needed, anticoagulate well, and address any patient compliance issues if you're having the, recurrent problems or risks with the pump thrombosis, and maintain an adequate preload. Infection is going to be important. It's one of the main problems we have with current LVADs, and it's a major issue. So again, you want to select well your patients, change all the catheters, make sure your antibiotic prophylaxis at the time of implantation is good. And in terms of preparing the patient, you want to scrub, keep the UR time short, and reduce any tissue dissection and bleeding. For remote infections, if they had any dental problems, you want to make sure that that's taken care of before. Urinary tract infection, sinus or bowel or skin, anything like that, you want to treat it before very aggressively. Any, you know, in the OR, the typical things we already do, but this is some extra. If you want to keep the doors locked to the OR so people stop coming in and out, sometimes in some centers, this might be a big issue. The prophylactic antibiotics, you want to make sure you're giving the adequate ones for the right patient. You know, scrubbing techniques, which should already be a standard. And then minimizing OR and cardiopulmonary bypass time. You want to go as quick as possible. I think you should do the less dissection as possible. So limit the incision size and all these things to try to keep all the tissues intact. That's going to limit the amount of infection you're going to have. Limit the amount of blood products. You want to be aggressive with bleeding. If there is post-op bleeding, I usually take this patient's back very aggressively. Try to limit the amount of blood products they're going to get. Glucose control is going to be good. The more control they are, the less infections they're going to have. And the driveline exit site placement is going to be very important. So there's a 50% reduction in infections on HeartMate 2 driveline infections when the valure is completely internal. So this is very important, and it does help. And some surgeons are still putting the velour on the outside of the patient, and it increases the risk of infection. The other thing to consider where you're putting the dry line is going to be if the patient's left-handed or right-handed, just because if they're left-handed and the dry line's on the left, it might have a lot of movement and interactions with that. And also for showering, it might be an issue. So the dry line has to be as immobile as possible. The more it moves on the skin and pulls on it, the more it's going to create a tunnel and get infected. And you also must be sure that the patients have antibiotic prophylaxis after surgery. There's staging of the dry line infections, and they start, of course, at very superficial in stage 1 to patients who have tunnels going along the dry line in stage 5. They're very difficult to treat. Once they're colonized, they really don't go away. There's things you can do to temporize, like keep opening and exposing, but then you're going to have less dry line that's unavoidably going to get infected, and you're going to have to keep on doing that until you get to the pump. So it's not an ideal problem, and I would say all patients will get it eventually. And then in terms of hemodynamics, you want to keep the adequate LVAD filling pressure. So these are a little bit of the numbers that you want to aim for. CVP of 10 to 12, MAP 70 to 80 or lower, going a bit lower nowadays. Flow, you want a VAD index of 2 to 2.5 liters, so it's like a cardiac index. And then if you need support for the RV, you want to use melphalan or dobutamine. And slowly wean the inotropes. No need to be too aggressive on these patients. Pressors and nitric oxide, especially if they already have RV dysfunction. CVP more than 20 can have renal dysfunction, diuretic unresponsiveness, and acute renal failure. So you don't want to have a CVP that's too high. And if you need to do CVVH early, it's good. Keep those kidneys working. It's going to help. So sometimes it pays off to be aggressive with this. So as I said, a little bit of blood pressure monitoring. The heartbeat 3 is a continuous flow pump. So the patients don't really have a great pulse. Sometimes you might feel it, sometimes you might not. And that's why one of the questions is how you measure blood pressure, auscultation versus Doppler. We tend to use auscultation more because sometimes Doppler just can't do it. Or sorry, not Doppler, auscultation versus automatic. The automatic measurements can't do it. And then it's either auscultative or Doppler. They're a little bit different on the way they work when you use a Doppler versus when you listen to the sound. So that might be one of the discrepancies, but there's no real gold standard yet. Yeah, that's about it for that. Hypotension, of course, has to be managed. The first thing is to make sure the RV is working well. So have a good CVP. Turn off the Milrinone if the LVAD flow is good. So if you're flowing more than 4 liters, you know that your right ventricle is flowing well. So if you're hypotensive, might be the Milrinone more than anything. Then norepi can be useful, or vasopressin. And increasing the pump flow, if the flow in your LVAD is not sufficient, but you still have room in your pump speed, especially if your LV is a bit distended and your septum is bowing towards the RV. If you have a poor RV function but normal systemic vascular resistance, you want to keep nitric oxide to optimize that. Milrinone is useful, as I said, and dobutamine plus or minus epidop or dopamine. So you want to target a MAP of 70 in the acute post-op. The mean should not exceed 85 or 90. Hypertension, as we said, can decrease the forward flow and increases your PI. So managing hypertension is going to optimize the cardiac output of these patients. Also might reduce a stroke and bleeding due to hypertension. So some of these patients have that. So how to treat it: ACE inhibitors, beta blockers, hydralazine, and volume management. So low flow management, this is one of the biggest headaches. You're going to have a lot of low flow alarms. Usually it's going to be patients that are volume depleted in the very acute post-op. They might need some fluid. They might be bleeding. So you want to check all of these things to make sure that's not the case. If they have a high CVP and there's no evidence of LV collapse, they're probably volume overloaded. And what that means is that their CVP is high, meaning their volume on the right side is elevated. But if your LV is not collapsing and is working well, that means that your RV is able to supply enough blood flow to your LV. So your RV should be working. And then what you're going to think about is maybe your pump settings are on the lower side and should be increased, and watch and reassess. Then if you have high CVP with evidence of LV collapse, it means that your RV sort of pressure is backing up there and it's not making it to the left side. So that's usually RV failure. So that's the first thing you want to rule out there. Pulmonary hypertension can also happen, but these patients are not immune to having primary pulmonary hypertension for other reasons. Tamponade has to be ruled out, or obstruction. So in terms of arrhythmias, it's also a controversial topic. There's some that are very obvious. If you're in ventricular fibrillation, you're going to have low flows, low power, low PI, and pulsatility events. So you want to treat that. Usually electrolytes, hemodynamics, if they're on high dose epi, that might cause that. Sometimes the elevated pump speeds because the LVs collapse. So you have this kissing effect between the walls of the LV that can trigger arrhythmias. Or the inlet cannula is touching the septal wall that can cause that. So that can be treated. Management, so those are very clear. And the question is going to be if this patients need to have an internal defibrillator or not. And if they're having a lot of arrhythmias post-op, usually we tend to install them. If sometimes these arrhythmias won't affect the patient that much and they can go into VTAC without issues. And if it's something continues and they're getting shocked all the time, sometimes we even disable the defibrillator. So sometimes it depends on the patient and what's the context and what's going on with them. The other thing is that sometimes the defibrillators the LVAC can interfere with the defibrillator and just be constantly shocking, thinking the patient's in VTAC, but it's just electromagnetic interference, and then it must be turned off. So some of the typical parameters in terms of the speed or RPMs, we're looking at those numbers, 4,800 to 6,400 RPMs. Usually it's around 5,400. The flow is going to be between 3 and 7 liters, usually around 4.4 power. That's between 3 and 6 watts. Those are the parameters that we're going to be watching. And then to find the optimal speed setting, we're going to look at what should be the normal for that patient, what's the left ventricular size, if there's any septal shift, and how often does the aortic valve open. And I'm sure you've heard about the ramp studies. So what you do is you go to the low end of the speed range, so you decrease the speed to see when the aortic valve opens at each beat. That's your lower end. And then you go at the high end of the speed range to see when the septum is flat and the aortic valve is closed most of the time. And that tells you what's going to be the higher end of your ramp study. And then what you do, you're going to go in between them. So midway between the low and high, it's going to be your ideal place. So what it says here is ideally 400 RPM, less than the high end speed. And what you want is the aortic valve to be opening once every twice or 3 times per heartbeat. That's going to give you usually the right outcome. So do we actually help? Do we get a benefit from this? So this is something that Abbott likes to show off. It's a comparison of results from different interventions at different times, but it's comparing very different patients. So I would always take this graph with a grain of salt, but you might see it all over the place. And it's showing you what's the survival of patients in different studies with different things. Here we're comparing different, we're looking at heart transplant. It's telling us it's 82% survival at 2 years. And then HeartMate 3 is 79 survival at 2 years, which is very good and close to it. And then you have medical therapy at 61, medical therapy at 49, medical therapy at 28. So it's all going to depend on which trial we're talking about. And they try to tell you, we have the same results as heart transplant. But this is not a study itself that got all these numbers. It's different studies and different things. So they're mixing things. The latest study that they have is the Momentum 3. And the idea is to compare their HeartMate 3 to the HeartMate 2 and see what's better. And they're looking at 2 years. So the primary endpoint is going to be survival at 2 years, which should be free from disabling stroke or reoperation to replace or remove a device. The secondary endpoint is going to be any pump replacement at 2 years. And other secondary endpoint is going to be actuarial survival, REOS, functional status, etc. So we'll look at that. These are the patients that got enrolled in the study, and we see that the majority are Intermax 2 to 3. And we see the results here in terms of event-free survival, comparing HeartMate 2 to HeartMate 3. It's very good for HeartMate 3. And here we have, depending on what type of population we're looking, bridge to transplant versus destination therapy. And we'll see also a difference that's maintained in both populations. And the freedom from pump exchange also, it's fantastic for the HeartMate 3, it's worse for the HeartMate 2. So 2.3 and 11.3 if you compare like that. This is freedom from pump thrombosis. So you see again, much better for the HeartMate 3. And this is by cohort, always much better for HeartMate 3. This is the same thing, pump exchange. So HeartMate 3 had very low pump exchange compared to all the other ones. And here we see HVAD had a 9% in other trials and 6% in another trial. So it's clear that HeartMate 3 is a better pump. And it's probably one of the reasons why the HVAD pump was pulled, because the monetary investment that they would have needed to do to improve it was probably not worth for them, given how superior the HeartMate 3 was showing to be. So it did not wait, they just stopped it. But it doesn't mean that the HVAD is really a bad pump. So the freedom from all stroke, you see that HeartMate 3 is better than HeartMate 2. Same here, depending on the population. And from GI bleed as well, the same thing is maintained. So you see that the results are fairly good. This is in terms of their functional status, and we see the improvement that's maintained, and that it's a little bit better or the same between both. So there's a change, but in between both, it's the same. So there's an improvement for each group, but when you compare the groups, again, there's not much difference. So yeah, again, this is a little bit coming from the Intermax, and we're going to be able to see what are the real life results. And again, we see very good results in the current era, which is the HeartMate 3 era. So we're talking about 84% survival, free from any major issues at 24 months, while the other pumps or the other eras are much worse. And then so if you compare in the current era, HVAD versus LVAD, HeartMate 3, HeartMate 3 is having better results than in the HVAD system. So it is a better pump. And this is a little bit more of the same, showing us freedom from GI bleed, from major infection, from right heart failure, and from CVA. But you see a lot of these results are being extrapolated. So we don't really have data to say long term, but everything is looking like it's better for the HeartMate 3. And again, a little bit of the same. But you compare all LVADs versus HeartMate 3, you see the freedom from first stroke is better. So, if a patient's stroking every month, it's a different thing versus the first stroke. That's why this curve matters, because it's showing you that 93 patients at 2 years have had no strokes. If you're counting all the strokes, all the events, it's more than each patient. So. And this is freedom from GI bleeding in the current era as well. Again, better for the HeartMate 3. This is sort of the worst thing that we have from infection. For LVADs, which is infection. And we see HeartMate 3 is still at 59% versus HVAD at 49%. It's all going to depend a little bit of how we define the infection and things like that, but the rates are fairly high, and it's one of our main issues. And the way to fix this is to have a device that's fully implantable, that has no connection to the outside, but that's very difficult to do. It's been worked to try and do a sort of induction charging with a big panel that's implanted behind the back to be able to charge the device just with a vest or something like that. But they're having issues with heating and things like that, so it's not working well. But hopefully one day they'll get it. So as a conclusion, LVADs are a great tool, and they can treat the sickest of the heart failure patients. They require large resource use and mobilization, and outcomes keep improving, which with each iteration. Patient selection and environment support are crucial. So thank you. I don't know if you guys have any questions or anything else that needs to be discussed.
Amazing. Thank you so much, Dr. Drullinsky. That was a great talk. So I can see here in the chat that we already have some questions. So we'll start with those. And if anybody has any other questions, feel free to put them in the chat. I'll keep reading them out to Dr. Drullinsky as we go. It looks like we have probably about 20 minutes or so to answer questions. So the first question we have here is from Ali. Thanks for the great talk. What's your threshold of TR for repair when you're implanting a VAD?
So thanks for that question. It's a good question, and there's no clear answer. If you look at the older data, we were not repairing TR most of the time. There were some groups that were doing it routine, but in general, it's not the valve that's addressed often with LVAD. And one of the problems is the survival for HeartMate 2, HeartMate or XVEs were very low. they didn't live long term and they didn't have a lot of recovery. Now, what we're seeing with the newer generation LVADs is that they do have a lot of recovery, and they are able to improve. So they're not just patients that are lying down. Many of these patients are quite active and trying to do a normal life. And if they have a tricuspid valve that's very incompetent, they're going to be very symptomatic and it's going to be very bothersome. So in general, I tend to be aggressive in treating the tricuspid valve. If it's dilated, for sure, as I said, 44 millimeters, although that's a completely random number. And if you look at the tricuspid repair data, why 44 millimeters was chosen as a cutoff, there's no real reason. But it's just to make a difference for me in my mind. If the annulus is very dilated, I'm going to address it. If it's severe TR and the patient's symptomatic from that, I'm usually going to address it. So I tend to err on the side of taking care of that valve. Now, that it won't change much for that patient because the only difference will be the bicable cannulation. I will do it on a patient who's on pump beating hard. So there's no cross clamp time for the tricuspid in these cases. The only downside I could see is for them to have some electric conduction system block, which usually it's not a thing, but if it does happen, it might be problematic. But in general, I think they benefit, especially if they're going to be active and recover from their overall status.
Perfect, thanks. So the next question that I have here is from U of A. Has Aries HeartMate 3 trial changed your management regarding using ASA and warfarin versus just warfarin?
So as I said, I think that trial is important and it's helping us. In general, we're still giving aspirin to the patients, but if they have any bleeding event, we stop it. I think we need more evidence to be routine on that, but in general, we're okay.
Great. And then from Robert Schultz, we have, can you comment on how you use American versus Canadian guidelines in your practice, and if you ever find any difference that actually changes your practice in Canada versus the States?
I wouldn't say it's more guideline. If you look at the Canadian guidelines for heart failure and LVAD, they're not too comprehensive, or so I tend not to be too guideline oriented in those terms. I would say the practice is very different. They're very different between Canada and the US. Our resources are for sure much more limited on what we can do. So I would say we're more selective and who ends up getting an LVAD. And in terms of comparing, we do a lot of sicker patients than in the US. In the US, they do those sick patients, but the majority are going to be a little bit healthier just because they have the availability to do the LVAD to more patients. I think that's our main difference. In terms of the way we actually practice, I wouldn't say there's a major difference in how we do things, but it's more in who we select and how many LVADs we have available. So I think we have to more pick and choose and see. We want to treat sicker people, but we want to make sure that they benefit from it.
Great. The next question I have is from iPad. So for aortic regurg, do you prefer to replace the valve or do you prefer to place a Park stitch?
I prefer to replace it. These patients are not what they used to be. They're not patients that get the LVAD and then they don't move. So they're going to have a lot of residual myocardial function, and I kind of want that to be going. The other thing is when you do a Park stitch, you're going to have a lot more stagnation in the aortic root, which I don't want. There's always the risk of having some of the clots there to go into the coronaries and things like that and cause issues. So I think a quick, safe aortic valve replacement is usually fine for these patients. There's always exceptions and things like that, but in general, I don't think you're still arresting the heart to do a Park stitch. Now, I think that the other question is going to be, in some patients, are you going to consider doing a TAVI instead of replacing the valve openly? And that is an option. You might ask to get that done before the operation, for instance. I've been involved in a few TAVIs in patients with LVADs, and it becomes a little bit more complicated. You really don't want that ventricular wire to get into the device and things like that, but it can be done as well.
Okay, and then the last question that I have in the chat is, what are your criteria or cutoff LV and diastolic dimensions for mitral valve removal?
I don't think I've ever removed a mitral valve for any of these patients. I haven't encountered one where it seems like it would be a good idea to do it. I think if you have mitral stenosis, that might be a case where you want to replace it. And in general, for the mitral insufficiencies, I usually with the Alfieri stitch, they're fine. If they're not going to be fine, if it's way too dilated, I usually just leave it and not address it. But I think in general, if it's I'm worried that it's not going to work, I'll replace it more than remove it. Again, I think a competent valve is going to help you down the line.
Great,
Thank
thank
you,
you so
iPad.
much. It looks like we don't have any more questions, so I might just ask one last question before we take a quick break. I know that like xenotransplantation is kind of becoming one of the new kids on the block with cardiac surgery, and I was wondering if there's any concern with how this could impact durable MCS in the future.
I mean, I don't have any concern in terms of I'm not worried about the LVADs. If there's a better option, let's go for that. You know, LVADs are great, but they're a big sacrifice for these patients. They're, you know, a lot of them can't, you know, you can't go in a swimming pool, you can't go in the lake, you can't do any of the activities that sometimes they enjoy. Just standing in the rain is an issue for them. Even showering is problematic. So if you have something better than an LVAD, I'm all for it. I think it's good. If we can get rid of LVADs, that's a good thing.
Amazing. Well, I think that's all of the questions we have. Thank you so much again, Dr. Drullinsky, for this talk. This was really great. So for everyone else that's here right now, it's I guess 2:15 or almost 2:15 EST. So we'll take a 15-minute break. We'll just stay online, and then Dr. Lodewyks will start chatting with us at 2:30.
Awesome. Thanks, everybody.
To the CSCS trainee committee for asking me to give this talk. And I want to commend you guys for the work you've put into this program. I think it's awesome. I wish that when I was a resident, we had a national effort like this. So well done to you for organizing. We're going to talk about heart transplantation today. And I know some of you have heard some version of this talk and information before. I've spoken with the Winnipeg and Hamilton groups. I think I may have done a CSCS related talk a while ago, but repetition is always good. And I've tried to update it with some of the newer guidelines and things that are happening to try and keep things current. So hopefully we can be a little bit interactive. Please, I have some questions and things to think about during the talk. So please speak up if you've got answers and questions for me in particular. So, okay, so we're going to talk about indications for advanced heart failure therapy and some of the guidelines related to that, what a transplant workup looks like, some donor management stuff, organ procurement stuff, focusing on brain dead versus donation after cardiac death donors, then the actual surgical details about procurement and transplantation, and some of the post-op considerations. My only disclosures are, as Trees mentioned, so I did all my training in Canada until fellowship and then went to Duke to do my thoracic transplantation fellowship. And so I certainly understand the landscape of heart failure in Canada, but all of my training in heart, or most of my training in transplant and practice is in an American system. So I've tried to bring a little bit of both to this, and hopefully it's helpful for you. So we're going to start out with the case. This is a 68-year-old male. He's diabetic, a smoker. He comes in with a late anterior STEMI. He's got an occluded LAD, multivessel disease. He gets some stents and a balloon pump. Initially, his EF is not great, in the 20 to 25% range. He's in AFib. He gets cardioverted, not so bad at the time. But then as he progresses, these are his hemodynamics. So PA pressures, not terribly abnormal. CVP is okay, wedge pressure elevated. O2M is low, index is low. He's on a lot of drips. So dobutamine, milrinone, amio, balloon pump. Despite all this, he still has a low index. So when you're preparing for the exam, I don't know how many of you are ending or nearing the end of your residency, but they like to ask questions about the ICU and ICU management of our cardiac surgery patients. So can someone tell me what is a normal mixed venous oxygen sat?
Greater than 65.
Yeah, somewhere around 65, 70, great. And a normal SVR?
Well, less than 3 Woods units.
Yeah, so usually so it's SVR, not PVR. I'm not sure if you're referring to that. So SVR usually is in the
Sorry.
800, that's okay, 800 to 1200 range. And then a bigger, a little bit more complex question, what are some of the things that define a patient in cardiogenic shock? There's a little more to that one. So in the classic definition, it comes from the shock trial, which is quite old. And this is related or sort of centered around blood pressure. So difficulty having a systolic less than 90, despite medical management, evidence of end organ dysfunction, a cardiac index less than 2.2, and elevated wedge pressure. But this has been updated. So this is from 2019, but the SCAI classification of shock has broken it down into 5 sort of segments or sections, stage C being the more classical one. And so you can refer to the paper, but basically there's a really nice table that talks about kind of the progression of the shock patient to the point where they are in refractory shock despite medical management, and we need to try and do something more for them. So our patient, after all this, on all that medication and the balloon pump, his LV functions about 10%. His labs are showing signs of trouble. So his creatinine's bumped up, he's hyponatremic, INR is a little bit elevated. When we talk about the heart failure patient in shock, one of the things we think about is what his Intermax score is. Does anybody know, based on what I've told you, what that might be? So on inotropes, not making any gains, maybe heading the wrong direction.
So it'd be Intermax 1 or 2.
Close. He's Intermax 2 for sure. So that progressive decline sliding fast. Intermax 1 is really the crash and burn, actively trying to die, like need to do something right now. Intermax 2 declining despite inotropy. Intermax 3 is a patient that's stable, but they're inotrope dependent. Usually 1 to 3, these patients are in hospital. And then beyond that, these are patients at home, and their various definitions based on their symptom severity. So this is also really good exam fodder to know Intermax score. And really determining Intermax score helps us decide what type of advanced heart failure therapy the patient might need. So I'm on call, and the cardiologist in the ICU asks me to see this patient to consider advanced therapies. So what are our options here? And really, when you have a patient in heart failure or shock, you need to think about a few things. So the type of shock, we talked about cardiogenic shock, but sometimes it's mixed. Maybe they have some sort of sepsis type presentation. And then what their Intermax classification is. Which pump is the problem? Is it their LV, their RV, or both? Are they having issues with oxygenation? And then are there clinical considerations about the patient and their medical history that might impact your decision on what type of options you have? So in this case, we're not going to spend a lot of time talking about MCS, but in this case, this patient needs something short term. Okay, they need something more than the inotropy and the medical management that can help get them out of this sticky situation. And so our short-term options are ECMO, Centromags, which are sort of a short to medium-term option for the left or the right side, a balloon pump, typically this is femoral, but can also be axillary, and then the Impella. And obviously there's multiple different Impella devices, and we could do a whole other talk just on Impellas, but usually the left-sided device is the CP, which is a smaller pump. It's the second one here with the pigtail that goes in through the femoral artery, or the axillary 5.5, which is a surgical device. And so then what do we do, and where does durable VAD and heart transplantation, or more what we call advanced heart failure therapies, fitting into this picture? And before you can make decisions about that, you have to think about the long-term goal and how we're going to get there. So we can use these short-term devices, but ultimately, where are we trying to get to? If you have a patient that's never going to be a transplant or a VAD candidate, you need to think about whether it's appropriate to use these short-term MCS devices in them. In somebody where you're not sure, maybe use a short-term device as sort of a bridge to decision. Or you're using a short-term device as a bridge to an advanced therapy, which you think might be most appropriate for them in the future. And the other useful thing for the short-term devices and using these bridges, as we say, is it helps us buy some time. So transplant workups take a lot of time. Even the expedited ones, they require a lot of testing. They require a lot of input from many different members of our transplant team. And so often in patients that are in shock and actively dying, it's really hard to get this done. So the short-term devices like Impellas, we put them in, stabilize them, potentially allows us to improve their end organ function, get them up, get them moving around, and then we have a little bit more time to figure out where we want to go. Okay, so for our case, we put in an axillary Impella 5.5, and I'm not going to get into details about this. If you have specific questions, we can talk about it at the end. And then we start thinking about what's next for him. So what are some indications for heart transplant in a broad sense? Don't think too hard. So there's two statements I think are important for you for studying and learning. One is a Canadian specific one, so the CCTN position statement, which is a little bit old now, but the ISHLT just came out with updated guidelines for transplant evaluation and care, and so they're very good. They're very succinct and super helpful. So I've got some information from both here, but really the main indication is end-stage heart failure. And that's 50% or more of patients that we evaluate for transplant. But when we say end-stage heart failure, what exactly does that mean? So this is the mnemonic that they use in the ISHLT guideline. There's others out there. Basically, a bunch of different criteria where in one particular patient, you then start to say, okay, we are at the end of our medical therapy and we need to look at advanced options. That's patients that are on inotropy, can't be weaned from inotropy, have severe symptoms and organ dysfunction, very, very low EF. If they have ventricular arrhythmias that can't be controlled and they're getting shocked. Multiple hospitalizations within a year, persistent volume issues despite their diuretic adjustments, low blood pressure, and that sort of fits with the inability to tolerate GDMT. Other indications, so ischemia, that's with debilitating chest pain, which can't be revascularized, ventricular arrhythmias, congenital heart disease, and then retransplantation. The absolute contraindications, this is a relatively short list, but PVR, so greater than 6 is an absolute contraindication. We're going to talk a little bit more about PVR in a second. Irreversible renal dysfunction and not a heart kidney transplant candidate, okay? Irreversible liver dysfunction and not a heart liver transplant candidate. Or active malignancy, and this is a bit of a complicated topic. The guideline has a very detailed section about pretty much every cancer you can think of and what the recommendation is as far as need to be cancer-free before considering transplant. So a little bit about pulmonary hypertension. This is the WHO classification of pulmonary hypertension. You definitely need to know this. We see PH sort of type 2 associated with left heart disease most commonly. And for workup of PH, this is where the PVR of greater than or equal to 3 comes in. So oftentimes we get patients in heart failure that come in and their PVR is elevated. So we need to determine if their pulmonary hypertension is reversible. Most of the time when it's related to left heart failure and elevated left-sided pressures, it can be reversible. And so this is a nice flow sheet that talks about how we think about it. So if you have someone with pulmonary hypertension that's elevated systolic pressure and either elevated transformer gradient or PVR, you can try vasodilator challenge. So I think we use Nornon most commonly because it doesn't have as much blood pressure effect as nitroprusside. If there's no difference, optimizing GDMT as much as possible, repeating the right heart cath. If that doesn't work, then we consider putting something like an Impella in. So you get active LV unloading, decrease their LV EDP, decrease their pulmonary capillary blood pressure, and see if you can reverse some of that. And sometimes it works. And then you can say, okay, this is acceptable, we can list them. Sometimes it doesn't work. And in that sense, then we look at VAD as a potential option. And in some cases, on a period of long-term durable or longer-term durable LVAD support, you can look at transplanting them in the future. Some relative contraindications of transplant, and there's many. Some of them are center-specific, but generally, people over the age of 70, if they have active infection other than an LVAD pump infection, if they have severe peripheral vascular disease that can't be fixed, bad diabetes with bad end organ damage, severe lung disease, the pH, which we sort of talked about, that would be in kind of 3 to 6 wood units category. Systemic infection, obesity is sort of a bit of a moving target. Most centers will have their own BMI cutoff. And then I feel like, at least at our center, this is where we stumble the most in patients that have substance abuse issues, psychiatric or mental health issues, and non-compliance with medical care. So specific to Canada, the CCS CCTN position statement, these are selection criteria. So they look at age, frailty, so these 3 different frailty scores, BMI, risk, right heart cath to look at pH, and then psychosocial evaluations. Most places, 6 months abstinence from substances, alcohol, drugs, things like that are required. So our patient is 68. He has diabetes, but otherwise no end organ complications. He has an AKI, but it's getting better. He's peeing. His creatinine's coming down with the Impella. Same with his liver enzymes. We'll say he was a smoker and quit 6 months ago, and his PVR was normal on his right heart cath. So then we start looking at the components of a transplant evaluation. We've determined on paper that he seems like a good candidate. We're going to initiate an eval, as they call it. What exactly do we do? Well, basically, we want to make sure that aside from his heart, the rest of the patient is suitable for transplant, and there's going to be no major issues that would potentially compromise his life expectancy or increase his risk for transplant-related complications afterwards. So extensive workup, all the cardiac testing, full lab panels, ID workup. They must get their vaccines. So this can be a sticky point. All of their usual vaccine series must be up to date. They must get a COVID vaccine. They have significant cancer screening, and then psychosocial screening with our social work and case management team. And then, of course, you need to know their blood type and antibody situation. So I'm not going to belabor this point. You guys should know about blood typing and what can donate to what and which recipients can accept from what. So this is also important for exam studying. So when we're looking at antibody testing and trying to determine donor organ matches for patients, can anybody tell me what a PRA is?
Don't know what it stands for, but it tells you what the risk of antibodies is going to be.
Yes, exactly. And so basically what they do is it's looking for, so the classical PRA is looking for the percentage of a population that the recipient would develop antibodies against. And this historical one is based on 100 donors and their kind of antibody profile and the patient's actual serum, and then it gives you a percent of reactions or panel reactive antibody, okay? If it's greater than 10, we consider somebody allosensitized. If it's greater than 80, there's a very high likelihood that the recipient's going to have antibodies to a donor, okay? And so each center determines their own threshold and then their protocol as far as what they're going to do when somebody is allosensitized or has a high PRA. And there's 2 other methods now for determining that. The calculated PRA is used more often than the classical PRA. It uses HLA frequencies from 12,000 kidney donors in the US. And so they create this panel and then determine the percentage of possible donors that would have antigens not compatible. it's more accurate essentially because it uses more data. The other is called a virtual cross-match, where they actually compare, so they do testing on the recipient and the donor to determine their HLA profiles and then directly compare the profiles. So it doesn't require donor and recipient cells to meet exactly. It can be done fast, and so it allows for faster decision-making regarding accepting donor organs. So at our institution, we consider any one recipient with a PRA greater than 0. We do a virtual cross-match. And then if they've had a sensitizing event, which we'll talk about in a second, we do a prospective cross-match. And what that means is we require physical donor and recipient samples to be mixed and tested for cross-reactivity. Obviously, this is more time-consuming, and depending on the status of the donor and timing, a donor center or OPO, which is organization for a region, might say, we're not doing prospective cross-matching for this donor. So 3 things that increase PRA, or these are sensitizing events, would be if they've had a previous transplant, if they've had a significant amount of blood product administration, or if they're female and have been pregnant. What do you do with a patient that has high PRAs or is sensitized? Generally, we consider these if greater than 50%. We try and avoid transplanting if it is greater than 80. There are centers that will do it, but they tend to be the higher volume centers. And so there's multiple things that can be done, pre-treating the recipient ahead of time, IVIG, monoclonal antibodies, and then using plasmapheresis or plasma exchange either prior to and or on pump at the time of transplant. All of these things are possible. There are protocols that can make it work, but it's definitely higher risk. Okay, so we mobilize a very big team. This is cardiologists, surgeons, social workers, pharmacists, transplant coordinators, and then any sort of allied health professionals that might be specific to the patient that weigh in and meet and decide what to do and whether or not they are confirmed a candidate. So our patient gets evaluated, passes, so we list him for transplant. What would be his listing status? This is tricky. Anybody have an idea?
I think in Canada he'd be status 3, but in the US I'm pretty sure it's a reverse order.
Yeah, good, close, good. So they are different. We'll talk about that too. The CCTN, the last revision I knew of is from 2021. And so it starts status 4 as being the highest status. And there's lots of criteria here, but basically these are patients usually on biventricular support of some sort that cannot be weaned, and they need a transplant. They get prioritized for a transplant fast. Okay. In Canada, there's the status S sensitized, which is a modifier for patients that have high PRA. Obviously, if patients have PRAs that are elevated, it makes it harder to find a match for them. And so that modifier is an indication of that and can try and help. So our patient's actually status 3.5. So the temporary surgical VADs, including Impellas and balloon pumps, things like that. I guess it would be more like this third option. Pericorporeal would be more like a centromeg. So he would be status 3.5. And then status 3, 2, and 1. I mean, you can look online and sort of weed through the details of these things, but there's a lot of detail related to this. In the US, you're right, it's reversed. So status 1 is our highest priority, but similar characteristics. So if somebody on VI ECMO, biventricular device, severe ventricular arrhythmias. In this category, status 2 is where the temporary MCS devices fit in. And this listing criteria was updated in 2018. And so since then, they've included the temporary devices and actually bumped up the status of those patients. So there's a lot of strategy now in using them to get patients' organs faster. And then status 3, status 4, and there's additional modifiers and things related to that, but it is different. So we list our patient as a status 3.5, and then the transplant cardiologist that's on call calls you to say that an organ's become available. So what do we do about that? Obviously, we have to determine if the organ is a good match for our recipient. So donor organ evaluation, also a big topic. There's multiple guidelines that have come out talking about this. One of the big ones is age. And so obviously younger hearts tend to work better. The donors are less likely to have medical issues and conditions that affect the heart, and they tolerate the transplant process and ischemic times better, okay? You can use older donor hearts, but we do that. We try and keep the ischemic times short if we can. Avoid using complicated recipients where you're already a little bit worried about transplant outcomes. Maybe they're higher risk. And donors over the age of 55, generally not used. Although if you had a patient, a recipient that was on ECMO, super sick, you know, potentially going to die, and you just need an organ for them, if you have a 55-year-old heart and it looks good, you may accept it. But I think that those instances are rare overall. You need to make sure primarily that the size of the heart is going to match your recipient, and most importantly, that you're not undersizing too much, okay? So you don't want the donor body weight to be any more than 30% less than the recipient. They can calculate this donor mass or heart mass donor recipient ratio. Generally, female donor to male recipient is safe if you meet the size criteria, okay? Past medical history. So we do use organs from HIV, hepatitis positive donors. The recipients are consented specifically that they will accept organs from these. So not every recipient will say yes, but we can use them. And if someone has or if the donor has a history of cocaine, alcohol, or drug overdose, we use those hearts relatively frequently, as long as their heart function is normal and there's no other concerns. Obviously, they need to be compatible, ABO compatible. We also want to know the cause of death. And sometimes this is a little bit shady or uncertain. And if it's truly unknown, our biggest concern is that it was an arrhythmia that was not witnessed, and the potential donor heart could have arrhythmia issues in the future. Chest trauma, it has to be pretty severe chest trauma to be worried about the heart function, especially if it looks like it's normal otherwise, or if there's prolonged time of low blood pressure or hypoxemia, then you want to be a little bit careful. Specific to the organ, you want to make sure they don't have coronary disease. Generally, if they're younger than 45, unless they have other risk factors like significant diabetes, hypertension, dyslipidemia, smoking, sometimes substance abuse, it's usually fine. If they are older donor, you certainly would want to try and get a cath. If they have risk factors, get a cath. And we don't usually use hearts that have obstructive disease. I must admit, I guess technically you can do a transplant cabbage, but I have not seen it. We try not to use them. We want to make sure their heart function is good. If it's not, then we don't use it. Sometimes the heart function isn't great initially, as it's sort of dealing with the stress of whatever event the donor's gone through, but it can get better with optimization of the donor hemodynamics. If the donor has a bicuspid valve, as long as it's working fine, you can use it. Other abnormalities, valve abnormalities, again, hypothetically, you can replace them, but I don't think that's really common practice. And the other thing we look for is LVH. So if you have greater than 13 millimeter septal posterior thickness, then you would avoid potentially. And as I was saying, you know, just because the EF initially is low, doesn't mean it's not going to improve. So you can have the the OPO or wherever the donor is being cared for, get started on the medical optimization pathway, repeat the echo, and see if it's improved from there. One of the other big considerations for donor organs is logistics. So where is the organ? How far do you have to go? How long is the travel time? Ideally, in a brain dead donor with regular cold storage, we want the ischemic time to be less than 4 hours. So that's the time from cross clamp in the donor, travel time to getting it into the recipient. You can stretch that with cold storage if it's a young heart, if it looks really good, if donor's not on any vasoactive support, or if we use the OCS machine or ex vivo perfusion, which we'll talk about a little later. Resource issues are important. So who procures for you? Do you have in-house surgeons? Do you hire a company to do it? What's the weather like? How are they going to get there? And then what's the timing of the procurement? And can you facilitate that with your recipient? Type of procurement depends a little bit on the type of donor, but if there's special equipment needed, how are we going to facilitate that? And then is the recipient an in-house patient? Are they coming from home, which may be a certain distance away? And are they a redo? Do they need any additional treatment prior to? So lots of things to consider about that. Okay, before we move on to different donor types, does anybody have any questions about transplant evals, workup, things like that?
Not to be too basic, but just for indications, like those initial 2024 guidelines, I would just struggle with it because to me, what the read is, they're just sort of saying like, get a heart failure team involved if you're concerned about advanced heart failure. Are there like UNOS cutoffs somewhere or something like that with like cardiac indexes we should be aware of?
So the major, I mean, there's certainly hemodynamic criteria, at least in the United States, as far as listing a patient for transplant and what they have to meet. And that is sort of tells you, they have to meet X criteria to be able to list them at this status. And that's a little bit more detailed, but essentially in the ISHLT, it's this, okay? So first determining that a patient has end-stage heart failure and needs advanced therapies. And then from there, what advanced therapy are they a candidate for? Does that help?
Yeah, great. Thank you very much. Appreciate it.
Anything else? Sorry, I should have just, hold on, let me go back to my other slide. Okay. So donor types. So DBD is donation after brain death. DCD is donation after cardiac death. It sounds silly, but to be a DBD donor, they have to be confirmed to be brain dead. And that's using the official adult determination of brain death. That is standard process in ICUs. And so they go through all of this, and if they are brain dead, then they go down the brain dead donor pathway. If they're not brain dead, or as I've had happen, the family doesn't consent to brain death testing, then they can be going down the donation after cardiac death pathway. And you may have heard of the Maastricht criteria. And so any planned cardiac DCD procurement is considered a category 3. So this is a planned expected withdrawal of care, and then cardiac arrest and cardiac death. So for the DCD organ donation pathway, usually there's still a severe neurological injury. It's just not enough to meet legal brain death criteria, or as I mentioned, maybe they won't test for that. And then they go down this DCD pathway. And so we withdraw life-sustaining therapies. Usually that means extubation, and they are taken off any vasoactive medications. And we wait for asystole, and then confirm once asystole that there is cessation of circulatory function, and then they're considered dead. That asystole must happen within a certain time frame for us to proceed with retrieving the organs. And so this shows it in a little bit different pathway, but So we start off with withdrawal of life support. We wait for circulatory arrest, and we can wait for a long time, sometimes hours. And most donor centers will have a policy about how long they will allow us to wait for the donor to have a systolic less than 50. That's when we consider the functional warm ischemic time, which we'll talk about in a second. But we can wait hours. Once they hit that systolic blood pressure goal, then they need to have asystole within about 30 minutes to be considered a DCD heart donor. Once they have asystole, we wait a further, usually it's 5 minutes. And then as long as they are still, in asystole and essentially dead, we proceed with procurement. Now, the biggest thing with DCD organ procurement is we need a way to make sure that the heart is going to work, because it is stopped. You've had cardiac death. And so there's 2 different ways to do that. One is with thoracoabdominal normothermic regional perfusion, which is a mouthful, but essentially TANRP or NRP. The other is direct procurement and perfusion. So we're going to talk about these separately, but essentially NRP is cannulating the donor after they've passed, cannulating the donor for ECMO, occluding their arch vessels, so preventing further circulation to the brain, reanimating the heart, assessing it using visual echo functional parameters and also metabolic parameters. And then if it looks good, you proceed with a regular sort of brain dead donor type procurement with flush cold storage. Direct procurement and perfusion is essentially the OCS machine. So you do arrest the heart, do the procurement, put it on the machine, reanimate it, evaluate it on the machine, and transport it on the machine back to the recipient center. Functional warm ischemic time is that period between when the blood pressure is less than 50 and when the heart is procured, okay? And so we want this period between essentially hypotension, significant hypotension, and circulatory arrest to be around 30 minutes. Then you do your standoff, then you open the chest. So NRP, some of the advantages of it are it's continuous warm perfusion in the donor. Okay, so it restores heart function quickly. You can assess it within the donor, whether or not it's viable. It reduces that warm ischemia time, and you get an idea before you leave the donor's chest, basically, whether or not it's going to be good. The equipment is less cumbersome than OCS, although you still need an ECMO circuit. You have to bring an ECMO circuit. You also need a perfusionist. There's a lot of debate about whether or not it's cheaper. A lot of centers now use procurement services for this, for DCD procurement and otherwise. And so really, I think when it comes down to looking at flight cost and procurement costs, it's not that much cheaper. The actual disposables probably are, but in the end, I don't think we can really tout it as a huge cost saving measure. The biggest issue with NRP really is ethical. And the reason why it's very region specific, state specific, even hospital specific as to whether or not they'll allow normothermic regional perfusion. And the concern really is around the definition of death. And a lot of places, the definition of death is essentially irreversible cessation of circulation. And so if you think about putting someone on NRP and ECMO after they've died, you've restarted circulation. And so do you still consider them to be dead? There's been debate about this concern for reanimation, but I think that's widely been disproven to not really be truly possible. And so that's the biggest thing. And the logistics are still challenging. I mean, you need personnel, you need people to do it, you need equipment. So it's not necessarily as straightforward as a brain dead donor. Data for NRP, so the initial studies came out of Papworth and St. Vincent's in Australia. These were small single center studies looking at direct procurement, perfusion, and NRP, which basically showed them to be equivalent. we've got just recently new data looking at the UNOS registry database, which captures all procurements in the United States. This is one from earlier into 2024. They had DCD donors from January 2019 to December 2023. Most of them were with the OCS at this point, and about 300 with NRP. And overall, they found perhaps increased survival with NRP donors in the whole cohort. But when they looked at their high volume centers, there was actually no difference. And there's a follow-up publication. So these are both Duke publications, but this one looked at a larger cohort. So they extended out to March 2024 and captured almost another 300 NRP patients, and found no difference in graft or recipient outcomes, no difference in unadjusted survival. The other was propensity matched. And interestingly, if you look at these graphs, the trend shows that NRP is now the most common procurement method for DCD transplant in the United States. So it certainly has grown if you look at the red bars on this graph in a very, very short period of time. So it'll be interesting to see how things change over the next year. The other issue that's interesting is there's a lot of data from the abdominal organ transplant world that actually shows that using NRP versus DPP for DCD donors results in improved outcomes in multiple different abdominal organs, livers and kidneys especially. And so this is also driving a lot of decisions in the donor world. And we actually had a case last year where we were offered a heart at a center and told that it had to be NRP and they would not allow OCS. And we didn't have capacity to do NRP procurement at that time, so we had to turn it down. But I think we're also going to be seeing increasing push from the abdominal teams to use NRP instead of the OCS in the future as well. Okay, any questions about NRP? Okay, so DPP, most commonly used device, I think the only FDA approved device right now is the TransMedics OCS. Requires cold preservation, so you flush the heart in the donor and procure it. And then you prepare and place it on the machine and reanimate it and transport it warm and beating back to the recipient. I won't get into too much detail, but basically the machine has multiple parameters that we monitor that tell us how the heart is doing and things that we can adjust to try and improve. The main indication for cardiac function is looking at the arterial and venous lactates. They draw them off this circuit. And if the venous lactate is higher than the arterial, we consider that bad and that the heart is secreting lactate. So that's sort of the major thing that we look at and that they report to us as they're transporting the heart back. Some pictures of, I'm not sure if you guys have had any opportunity to see what this looks like, but inside the console, all of the inner parts here that you see are disposable. And so there's this big box that gets opened and all the stuff gets put in and connected. And then you hook the heart up to the system and run it. There's this control panel essentially on the top left corner. And this picture of what the heart looks like on the box. So the aorta is connected to the cannula at the top, and blood basically flows sort of, I guess technically retrograde down to perfuse the heart muscle. And then there's a venous cannula that's attached and to the PA and drains into the system from there. We put temporary pacing wires on the heart. There's tiny little defib pads on the back, just in case. So good things about the OCS, it decreases ischemic time. You take the heart out, you get it on the rig. Usually it's about 20 minutes, half an hour to do that. And then you warm it up and get it beating again. And so you have warm organ perfusion. It allows us to assess organ function. It's expanded our ability to use organs both from DCD donors and brain dead donors, which we're going to talk about, the use in extended criteria brain dead donors and long ischemic times. Some disadvantages, I think the main one really now is cost. Most places in the US don't have their own Transmedics procurement team anymore, because Transmedics now provides a procurement service, but the cost is still a lot. The disposables alone are $50,000. There's a lot of equipment that goes on these procurements. So the transportation logistics, you have to have a plane that's big enough to fit all the stuff and your personnel. You still need a perfusionist or preservationist to run the machine. And from a heart perspective, these tend to be a little bit boggier, have a little bit higher incidence of PGD and RV dysfunction. It's kind of hard to predict. So this was for my fellowship, our team, we went out on a run, and so we always had 7 items that we had to sort of make sure we had with us. The machine itself, there's a base that has wheels on it, the disposable box, which we don't have because this is after the procurement, which is huge, and we would carry around with a dolly. The run bag, which is this red bag, it had all of our miscellaneous equipment in it, a drug bag, and a cooler. So there is good data about the use of OCS and DCD hearts. This is the DCD heart trial, the original one, that compared DCD OCS donors and brain dead cold storage hearts. And it was 180 patients from 13 centers. So they had really, it was a non-inferiority trial, and their incidence of primary graft failure there was no difference essentially. DCD was considered to be non-inferior to brain dead cold storage. They did note significantly increased risk of PGD compared to the brain dead hearts though. But overall, they had really high rates of utilization of DCD hearts that previously were not being utilized, and excellent patient and graft outcomes. The other interesting trial is the EXPAND trial. So while we were looking at DCD hearts and how we can preserve them and use them, this is about extended criteria brain dead donors. So ones where we may not have accepted them in the past because of whatever specific criteria would make them high risk donor, that allow us to use the OCS machine to optimize them and then transplant the organ. And so in the trial, they considered extended criteria donors to be those primarily with long cross clamp times, so more than 4 hours, or long-ish time plus a risk factor. So they were old hearts, maybe they were older and they didn't let you do a cath at the donor center, long down times, maybe sort of borderline LVH, borderline LV function. And so you can still procure the heart as a regular brain dead procurement and then put it on the rig, perfuse it warm, assess it, and potentially use it also. So it's a single arm study. They had 150 successfully transplanted hearts out of the extended criteria. It was 87% of the hearts that they put on, and primarily the ones that they ended up turning downward because of concerning lactate trends. And their outcomes were excellent. So 30-day survival without severe PGD was over 90%. 30-day survival overall was 97%. Severe PGD rates were very low, and longer term survival, so up to 2 years, where it was essentially comparable to non-randomized transplant recipient controls. So both of these studies led to the FDA approval of the Transmedics system for both DCD heart procurement and brain dead donor extended criteria hearts. And interestingly, so the development of Transmedics as a company has been kind of interesting to follow, but initially it was the centers that were responsible for doing the procuring. Then Transmedics in spring, summer 2022 developed its procurement service. So you could call them up and say, hey, there's a DCD donor in this place. Can you please go procure it for me? And they would send their own procurement surgeon out there and their preservation team and bring the organ back to you on the box. And that's really taken off. And especially in places that are small and can't support their own procurement teams, it makes it really, really easy. And so because of the popularity of this, I guess almost 2 years ago, 1.5 years ago, they announced that they have basically created their own plane fleet. So this takes out yet another variable where before they're relying on private charter companies to provide their flight paths. now they can do what they want with their own pilots and their own planes. So they're continuing to grow and facilitate DCD organ procurement across the country. So when I was a fellow, the furthest we went was from Durham to Puerto Rico. That's a 4-hour flight. So this was a brain dead donor that we used, I guess, extended criteria OCS to bring the heart back, and we had a great result. As far as DCD transplant in Canada, it's lagged behind significantly, I think primarily due to the ethical reasoning and the brain death definition, circulatory death definition that was previously in place. I don't know all the ins and outs of this because I don't really live this every day, but if you're interested, it may be worthwhile looking up this guideline from the Canadian Journal of Anesthesia, where they actually changed the definition of brain death and circulatory death to try and become a little more aligned with DCD donation and facilitate that. And so the updated definition is death determination by circulatory criteria is made based on the absence of extracranial circulation that leads to the permanent absence of intracranial circulation. Okay, so basically saying you're going to clamp the head vessels and we're not going to have cranial circulation. And so I mean, and again, as far as DCD donation in Canada, I know that they have done, or first one was done in Toronto, I think last year. I'm not sure how many they've done since, but hopefully things can progress a little bit now so that the DCD hearts can be used. DCD donation for other organs has been ongoing in Canada for many years, but those hearts get discarded. So hopefully we can get that going. Any questions about OCS?
Just I've heard one of the arguments in Canada is that there's still intercostals and whatnot that can somehow, perfuse the brain during like NRP specifically.
Yeah.
Have you seen any evidence of that when you guys are doing NRPs? Like, there's still, if you're doing RCP for example, like there's still blood coming out of vessels around the neck or head area.
Yeah, so it's not just in Canada, it's debated all over the place. And there's a lot of literature about it. And technically it is theoretically possible, but I think the argument that people will make is these donors have usually had some sort of severe neurological injury to begin with. And even if they do have intercostal blood flow, it's never going to be significant enough to reanimate their brain, right? And so I think most people feel that physiologically, is it possible? Yes, but you've ligated their major blood supply to the brain. A normal person could not sustain brain function by an intercostal artery. So it definitely is still part of the debate, but good question.
Got it. Thank you.
Another quick question. What are your guys' cutoff for how long you're allowed or you would want the organ to be on the OCS?
Yeah, I mean, it's a good question. I think it sort of depends on the situation you're in. I mean, we had the trip I did to Puerto Rico, our flight time was 4 hours. So that doesn't count I think our transport from hospital to airport was like 45 minutes, and then transport from the airport to the recipient center is another 30 minutes, plus the preparation. We probably were like 6 or 8 hours, but it certainly can be longer. And another nice use of the OCS machine, so if you have a recipient that you think is going to be a really horrible redo, LVAD explant, complicated redo, congenital, something like that, you can put it on the OCS machine and have it in your OR perfusing for however long until you're ready to use it. So that is helpful. I think when you start to get out, to the 7-8+ hour range, you're concerned about needing ECMO or having PGD for sure, but it's kind of situation dependent. Also good question.
And then maybe I missed it. Could you just give some color to your opinion on lactate after doing OCS?
Yeah.
How valuable you've been?
Yeah. So my opinion about it is colored by my fellowship experience, where they thought it was unhelpful. And so we actually routinely didn't put in a PA cannula, and we just let the heart beat. And so the venous drainage, the whole right side of the heart was decompressed and not part of a pressurized circuit. And they felt like that the RV outcomes were better. And so we only had arterial lactate trends. And routinely we would do DCD transplant with arterial lactates in the 5, 6, 7, 8 range, and they would be fine. But by the Transmedics IFU, you know, they're doing the procurements, they do it by their IFU, and they use lactates. And so I'm a little less concerned about higher lactates. If there are other things that make me concerned, like the heart actually doesn't look great when it's on the box and beating, that's another issue. But you can transplant a heart with a higher lactate on the box, and it can be fine.
Got it. Thanks.
I think they have to have something that they can quantify and to use to make adjustments on the management of the organ. And that's currently what they have. Yeah. Okay, good questions. So what about cold storage? Where does that stand? Historically, you take a brain dead donor heart out, put it in preservation solution in a bag, and then put it on ice in a cooler. Really, at least in the US, that's fallen out of favor. And a big reason for that is the Paragonix Sherpa Pack transport system. And this is basically just it's a glorified passive cooler. And so the heart is suspended in this plastic container that's filled with cold preservation solution, no ice, touches the organ, and then it's placed inside this cooler, which is passive. And so it's designed to maintain a uniform temperature inside the cooler itself, and for a long period of time. And so essentially the heart never comes in contact with ice. You don't have any chance of the myocardium freezing, which, you know, they've shown that the distribution of temperature of a donor heart on ice is very irregular, and you certainly can have freezing. And so there's a large registry called the Guardian Heart Registry that Paragonix runs with all donors that have been procured using the Paragonix Sherpa Pack. And they've found basically improved survival and significantly improved PGD related outcomes. Okay, so any PGD, severe PGD requiring mechanical support, any type of mechanical support, RV dysfunction, things like that. So really, it works very well. And when I started working in Minneapolis, I pushed to bring it in. I think myself and my colleagues, they've been very happy with our results and experience with it. Downside is it's not cheap. It's about $15,000 for the device. And so people argue, well, you know, ice in a cooler is cheap. But Paragonix has done a cost analysis basically and decreasing all of these complications, which are related to recipients being in the ICU for a prolonged period of time, needing expensive devices, ECMO, all that sort of stuff. In the end, it ends up with a cost savings. So $25,000 is what they figured out in their analysis. And so people are also starting to push the boundaries of what they can do with cold storage. So historically, we try and keep a ischemic time in a cold storage heart of 4 hours. The MGH program in Boston made news almost 2 years ago when they took a heart from Alaska on a Sherpa Pack and flew it to Boston. It was 25,000 miles, and the heart worked just fine. And so some of the bigger programs certainly are pushing the limits of how far they can travel using a Sherpa Pack, which is much easier and much simpler and much cheaper than an OCS or an NRP situation, or I guess OCS situation for DBD hearts. So also something that will be interesting to see how it affects our practice with ischemic time and transport. Okay, so I'm going to talk a little bit about how a procurement runs. I'm not sure how many of you work at a center where you get to do transplant. I'm just also thinking about the time. So I'm going to try and go through this really quickly. If you have specific questions, we can talk about it after too. But essentially, this brain dead procurement. You get to the donor site, you open the chest. The biggest thing is to determine whether or not you're going to use the heart. So does it look okay? Is it working okay? Is there any obvious abnormalities? Okay. Then you call whoever the implanting surgeon is to say, yeah, I think it looks good. And you give an estimate of timeline based on what other organs are being procured. Then you do a warm dissection. So you open the heart, the chest, the heart's beating. Basically, you want to free up all the structures that you need to detach to get the heart out in the simplest terms. Okay. If the lungs are also going, it gets a little bit more complicated. But you want to try and dissect as much as you can initially, because then once you flush and you're actually cutting the heart out and there's some time pressure, it's much, much easier. So I'm not going to go through this too much. When everybody's ready to go, so you're done, the abdominal team is ready, they've done the dissection they need to do, the donor gets given 30,000 units of heparin. You use a pleat cannula in the ascending aorta, and then you do the procurement. So you cross clamp the aorta, you give your flush, the abdominal team gives their flush, and you have to vent the heart because all this fluid's going into the right and left side. And that sort of depends on whether or not the lungs are going where you vent. So usually for the right side, you vent the IVC. For the left side, you can vent the left atrial appendage. You can vent in the left, in the interatrial groove or one of the pulmonary veins if the lungs are not going. And then again, order of operations, I'm not going to get into too much detail about this, but essentially everybody does it a little bit differently. You just need to detach all the things you need to take the heart out. Yeah. Again, with the lungs, you need to share, and sometimes that's hard. So there'll be a heart surgeon and some sort of thoracic or lung procurement surgeon. You have to share the PA. So they need the branch PAs, you need enough main PA. So you have to plan your lung flush cannulation and resection of the PAs accordingly. Same goes for the pulmonary veins and the left atrium. You need enough left atrium to study your recipient. They need pulmonary veins intact. And this can get a little bit hairy sometimes. And then when the heart is out, you take it to the back table and you need to make sure everything looks okay. So you inspect all the major structures, make sure there's no obvious abnormalities or injuries. If there's a PFO, you can close it on the table. And then you're going to prepare it depending on what you're doing, cold storage, or if you're doing OCS, you prepare for OCS. Okay. Any questions about procurement? I know that was like super fast, but. Okay. So back to the recipient. So obviously you have to cut the old heart out. And as mentioned, we need to think a little bit about considerations for that as far as timing. And once the donor heart is out, how long is it going to take to get to you and how much time are you going to have? If it's a redo, you obviously need more time. You might need multiple hours to open the chest versus a virgin chest where you open up, do your dissection, cannulate, and you're ready. And so that's important for timing consideration. And then your cannulating plan, usually distal ascending bicable venous. You can use the femoral vein for your IVC, gives you a little bit more room. You don't need to plege the heart. You just cross clamp it and it beats and you cut it out. And yeah. There's two techniques for doing the recipient implant. The historical being biatrial, where you connect the left atrium and then the right atria together. Now we do this bicavally, so we disconnect the SVC and IVC and sew them as separate anastomoses. The biatrial was faster, but they have increased incidence of mitral and tricuspid valvular issues, arrhythmias, things like that. So we do it bicable, adds an extra anastomosis, but overall works better. So once the donor organ arrives, you as the recipient surgeon are responsible for making sure that's the correct organ. That's step number one. So there's a whole check-in process where you make sure that the information that matches. And then you're going to take it out and do the similar things your procuring surgeon did. Make sure that everything looks okay. You don't have any concerns about injuries, potential complications. You free up the aorta and the PA, trim any extra tissue, and then start sewing. We always do the left atrium first. It's at the back of the heart. Once it's in, you're not gonna see it again, okay? And generally, this is 5 anastomoses. It's 5 circles. And usually, in my mind anyway, we sew a circle and then we do something. So for me, I sew the left atrium. When I'm almost done, I put an LV vent in. Some people don't even use an LV vent, but that's my thing after the left atrium. If you are doing a brain dead heart that's been arrested at the one time at the donor site and comes back to you after you sew the left atrium, this is a good time to give additional plegia. I use Del Nido, so 1 additional dose in the root is usually enough. Some people will do like Buckberger blood pleage after each anastomosis. If you're using a Transmedics heart, before you take it off the box, you actually arrest it using Del Nido then, and usually that's enough to get you through sewing it back. The rest of the heart implantation, there's variations. I think people do it a little bit differently depending on how you trained. I do the PA next and then float the swan before I finish my PA anastomosis. Anesthesiologists are happy about that. Then the aorta, then the IVC, then I take the clamp off and do the SVC. Again, there's varying ways to do this. Theoretically, one of my colleagues does it this way. You just do the left-sided anastomoses, the left atrium and the aorta, and you can take the clamp off because the rest are all right-sided, decrease your clamp time. But it does make it a little bit more painful because you have a lot more blood return. You have to try and see through the PAs kind of behind the aorta. So there's different ways to do it, and there's good reasoning for them. Any questions about implanting? Okay. And then in brief, real quickly, surgeon specific type stuff. Obviously there's an entire fellowship about heart transplantation, cardiology, and these issues, but a few of the things that they really like to touch on for the exam. So for early post-op considerations, really important. So this is one of my mentors in fellowship always said, you can have bleeding or RV dysfunction, but not both. If you have both, high chance you're going to end up on ECMO. So being really diligent, trying to make sure you have hemostasis, using a PA catheter to guide your hemodynamics, inotropes liberally, medically manage your RV, and don't have a short leash for advanced RV support if you need it. These are rate dependent hearts. Usually we pace them around 100 initially in the post-op period. Immunosuppression, huge topic. You should have an idea of the general regimen that the average heart transplant patient is going to be on. They all get steroid therapy induction, intra-op, pre-op and intra-op. Triple therapy is the general regimen, so they'll be on a calcineurin inhibitor, now more likely to be tacrolimus, an anti-proliferative, usually MMF, and then their steroid or prednisone. Okay, all the other alternatives or whatever, I mean, pharmacists do graduate work to figure all this out. But from a cardiac surgery exam standpoint, you need to know the triple therapy regime. Cytolytic induction therapy, it can be used if you're concerned about high risk of rejection in the early post-op period. And so these are usually antibody, monoclonal antibodies, looking at B-cell, T-cell depletion. And these can be very helpful, but the downside is patients have a higher risk of infection and lymphoproliferative disorders post-operatively. And obviously all these medications have side effects and they love to talk about them on the exam. So calcineurin inhibitors can be very hard on the kidneys. There's neurological side effects, azathioprine, bone marrow suppression, steroids, the usual complement of things. So you really need to know these. And then again, the different types of rejection. So staging as far as time course, hyperacute, acute, and chronic, and what defines these stages. And then how do we try and prevent it. So for acute rejection, tissue biopsy. And every center will have their own protocol as far as when patients get their first biopsy. Usually it's kind of 10 days to 2 weeks after transplant, and then they go on with an outpatient regimen after that. They get their right heart cath and biopsy to monitor. There are newer monitoring things. There's a cell-free DNA assay, which our program is using. And to be honest, I don't know the medicine about, but it exists. And the goal is to try and decrease the frequency of patients needing right heart caths, which is an invasive test. You need to know the different types of rejection. So acute cellular rejection being T-cell mediated, and then how is it graded? And then how is it treated? Okay. And then also antibody mediated rejection, how is it graded and how is it treated? So this is all in your textbook. It's important for the exam. Other important complications, obviously infection is huge. Early infections tend to be bacterial, usually around the time of surgery, pneumonia, depending on the difficulty of their post-op course, UTI, things like that. If they get infections late in their transplant life, they tend to be more viral, opportunistic, kind of rare transplant-associated infection. They are all on Septra for pneumocystis prophylaxis, and they all get viral CMV prophylaxis if they are, CMV positive donor. CAV, or chronic allograft vasculopathy, is basically development of coronary disease in the donor heart. There are risk factors, some of them similar to development of sort of native coronary disease, hypertension, males, things like that. They get screened for this. Treatment is a bit tricky. You can stent them, but it doesn't tend to work very well for very long. And I mean, I've never seen someone do cabbage, but I guess hypothetically you could. I think in patients where they develop advanced CAV, the next step is usually retransplantation. And then neoplasm. So any patient that's on immunosuppression for a prolonged period of time is at increased risk, so they get screening. Most common types of neoplasms tend to be lymphoproliferative and skin cancer. So that's it. Sorry, that's a lot of information, but I got it squeezed in. So I hope that you found it helpful. And if you have any questions or want me to talk more about something specific, please don't hesitate to ask. And otherwise, I want to thank you guys again for asking me to speak.
Amazing. Thank you so much, Dr. Lodewyks, for such a high yield and interactive presentation. So yeah, if you have any questions, you can feel free to either raise your hand on the Zoom or message in the chat. Currently, there's a few questions that have accumulated on the chat, so I'll just read them out for you.
Yep.
So Ali asked, what is your general perspective on tandem heart as an MCS device in the current era, especially as a bridge to transplant?
That's a good question. I'm going to be very honest. I have never used one. I kind of get the sense that it's center specific. I think with the rise in improved percutaneous devices like Impella, so we have left-sided and right-sided Impellas. We also have Protex that are really, less invasive. I don't think that tandem heart is really used that much. And it may be my experience here in the US where the Impella type devices, Protex and things are really readily available. It could be in Canada that maybe they're using them more often because you don't have the same access to some of those things. But yeah, I've never used one. A good question.
Thank you. And then Matthew asked, there have been talks across Canada about more encounters of primary graft dysfunction in heart transplant. Have you seen this in the States? If so, any theories as to why?
I don't know if I've heard that in particular. I haven't really checked data, to be honest. I imagine it's probably multifactorial, and it probably depends a lot on the donor profiles. And perhaps centers are being more aggressive taking hearts that they weren't taking previously, extending their acceptance of things where maybe the heart's a bit borderline. But honestly, even in the, of the hearts that we have that get PGD, which primarily tend to be the OCS hearts, but not always, you put them on ECMO for a few days, the heart gets better and they come off ECMO. I know of we did one emergent retransplant when I was a fellow for severe intractable PGD. And so I think that the incidence of needing to do that is quite low. Most of the time the PGD can be managed. And so while it's not great, certainly there's complications related to being on ECMO and patients being in bed and not mobilizing and all that stuff, longer ICU stays, more resource intensive. It doesn't necessarily mean that the heart doesn't recover. So I think it's probably a complicated situation, but interesting.
Awesome, thank you. Someone also asked, how VAD is responsible for high PRA apart from blood transfusion?
It's not. A blood transfusion would be it. Yep.
Okay, perfect. And then Kenza asked, thank you for the great presentation. More of a practical question. For DCD hearts, how do you coordinate with the recipient OR team for timing if you don't always know how long it will take for the donor heart to stop?
Yep, that's a really good question. So we tell the recipient that there's an organ and that it is a DCD organ. And basically they get updated. And so we don't move them. So if they're in hospital, they're usually on the ward or in the ICU. If they're at home, we might have them come into the hospital, depending on how far away the heart is. And then once the donor dies and it's confirmed that the procurement team is actually procuring the organ, we go and tell the recipient, the donor's passed, we have a heart for you, and then we start moving. Based on the recipient timeline, when we think that the heart will be there, etc. So yeah, we wait. And
Awesome.
sometimes that means if the donor doesn't die, the recipient knows it didn't happen. So they wait for the next one.
Awesome, thank you. And then Ali asked, is administering T3 still routinely done pre-transplant?
That's a good question. So in the donor or the recipient? Because I'm pretty sure they give it to the donor still. There's a whole list of medications and protocol that the donor gets.
They said recipient.
I don't believe so. I'm not a heart failure cardiologist though.
Awesome, thank you. And then, yeah, if anyone else has any other questions, those are all the ones in the chat, but you can feel free to unmute yourself or to message in the chat. Awesome. If there are no other questions, thank you so much again, Dr. Lodewyks, for
You're
your
welcome.
time and for teaching us across Canada for something that, because a lot of our programs don't have as much exposure to transplant. So this has been really, really helpful. And thank you everyone for attending our National Academic Half Day on behalf of the CSCS Educational Task Force, and we will be posting the recording onto the website afterwards. So thank you everyone for coming.
Thank you.
And hope you all have a great rest of the day. Take care.